Welcome to McTox curriculum. Our topic will be focused on aspirin and anti-inflammatory drugs. By the end of this 10 minutes, learners should be able to differentiate between acute and chronic aspirin toxicity and to discuss the management of each. They should also understand the mechanisms and effects of NSAIDs and overdose. Let's return to a case from a previous video. We have an 82-year-old female who presents with progressive confusion over 3 days. Her spouse says that she was fine until about a week ago, when she developed diarrhea for several days, followed by a strange ringing in her ears. She takes her medications regularly and denies any overdose. Her medications include aspirin, warfarin, furosemide, lisinopril, and atenolol. Here is her relevant blood work. It appears that she has some renal impairment and an elevated serum aspirin level. Let's compare case 1 to our second patient. This is a 26-year-old female in your department that states she took a whole bottle of over-the-counter aspirin about 6 hours ago because she was upset about her exam results. She regrets what she has done and is asking for your help. She vomited twice a couple of hours ago, and otherwise she's pretty asymptomatic. What else should you ask for this ingestion? It's important that we know the dose of aspirin ingested. She thinks it was 325 milligrams in the tablets she found at home, but she's not sure how many were left in the bottle when she found it. Based on the worst case scenario, she could have ingested a total of 32.5 grams of aspirin. Her vital signs indicate that she has started to become symptomatic with tachypnea. Her blood work confirmed her story, and a diagnosis of acute aspirin toxicity has been made. Aspirin is rapidly absorbed through the GI tract and undergoes metabolism in the liver. Some aspirin is excreted unchanged by the kidneys, and this becomes an important part of the management of aspirin toxicity that we'll talk about later. Aspirin has multiple mechanisms of toxicity, including direct stimulation of the respiratory center in the brain, inhibition of the Krebs cycle, uncoupling of oxidative phosphorylation, and inhibition of the cyclooxygenase enzymes 1 and 2, which result in decreased platelet aggregation. There are several other toxic mechanisms that we won't go into due to time. Multiple acid-base abnormalities can be present with aspirin toxicity. The 4 classic types are shown. Initially, a respiratory alkalosis is seen, which will progress to a metabolic acidosis, sometimes mixed with a metabolic alkalosis, and finally a respiratory acidosis as a late and highly concerning finding. The clinical picture of aspirin toxicity varies depending on its acuity and the general condition of the patient. Usually it starts with tinnitus, tachypnea, hyperthermia, and GI upset, followed by vital organ dysfunction such as altered mental status from acid-base and electrolyte disturbances, and shortness of breath from pulmonary edema. Our initial treatment for aspirin toxicity, aside from good supportive care, is urinary alkalization. Indications to initiate urinary alkalization can be grouped into 3 broad categories: evidence of systemic toxicity, an elevated aspirin level, or significant acid-base disturbances. There are several theories behind how alkalizing the urine is helpful. The trapping theory is the main one we will focus on. In an alkalotic environment, the hydrogen ion of a weak acid like aspirin becomes dissociated and traps the aspirin molecule in the urine, since ionized molecules are more difficult to reabsorb. This will trigger diffusion of more uncharged aspirin into the urine via its concentration gradient. Urinary alkalization with a sodium bicarbonate fusion also helps keep aspirin out of the target tissues and in the blood compartment. Dialysis is our definitive treatment for aspirin toxicity. Indications for dialysis are listed here and include hemodynamic instability, end organ dysfunction, severe acid-base or electrolyte disturbance, and acute and chronic aspirin levels. NSAIDs, just like aspirin, inhibit cyclooxygenase, which leads to gastric ulceration, renal vasoconstriction, in addition to inhibiting platelet aggregation. NSAIDs in overdose are not usually serious unless a massive amount is ingested. They can cause severe GI bleeding, renal impairment, and a metabolic acidosis. The treatment in these cases is usually supportive. Finally, we have 2 questions to leave you with. Question 1. What are the benefits of hemodialysis in aspirin toxicity? And 2. What are the causes for inability to alkalinize the urine despite an alkalotic serum?